Welcome to the Q&A for Where to Now for ovarian cancer screening. If you have any questions, please submit them in the chat box. I would now like to welcome Dr. Jacobs and Dr. Menon.
Hello there, everyone. Good to be here. Ian Jacobs.
Apologies, I just realized I was muted. Hello, everyone. It's good to be here. Ian is in Sydney and I'm in London. Look forward to your questions.
Can we ask questions now?
Yes, if you could just type them in the
Type
chat
them.
box,
Okay, fine.
then we'll take them one by one. Ian and I will take them alternately, at least start them off alternately.
Elizabeth, is that right? You want everyone to type their questions in and then they'll appear somewhere?
Yes, please, and then they'll be in the
moment.
chat box so you can see them.
Ian, if you click on that chat at the bottom.
Yeah, I can see the chat, but I can't see any questions yet.
Yeah.
So do fire away with questions. We're here comes the first one. So, well, thank you for the thank you. Yeah, we were delighted to be able to contribute to this meeting and present the results, and we're proud of the integrity of the way that the trial is being done. The question says, thank you for so honestly presenting these disappointing results. We've had such high hopes since hearing about the trial. So concerned about needing 5 years lead time. Can you speak to the challenges of detecting type 2 ovarian cancer? Well, I'll start off and then Usha will add, I'm sure. The good news about the trial is that it is possible to detect most women who have ovarian cancer before they develop symptoms. And this is a very large scale trial, 200,000 women participating for a long time. So it was a trial, but it was almost a real world trial across the UK. You can detect ovarian cancer early, before women get symptoms. And when you do that, you can shift the stage of ovarian cancer and shift it earlier, which is all good news. The problem is that that shift clearly was not big enough. It wasn't early enough to save lives. And so we then go on to speculate about how much earlier before clinical diagnosis would you need to detect ovarian cancer in order to save lives. We think that in UKCTOCS, it was something of the order of 18 months to 2 years on average before clinical diagnosis would have occurred. Given that that didn't save lives, it would need to be earlier. And maybe 4, 5, possibly even 10 years earlier. So that is a really big challenge for any early detection test. Some of the women in UKCTOCS will actually have had their cancer detected more than 2 years before clinical diagnosis. And there is evidence that using CA125 in screening can detect ovarian cancer up to 12 years before clinical diagnosis would have occurred. But the problem is that on average, it was less than that. That wasn't 2 years, 18 months was not enough to save lives. Usha, do you want to expand on that?
Yeah, I was just reading the questions. So I'll just take this as well as some other questions below. So with regards to the challenge of detecting type 2, which is mostly high-grade serous ovarian cancer, and the cancer with the highest, well, almost the highest mortality. So, you know, we did find that both in the ultrasound arm where the sensitivity was less and we didn't have stage shift, and even in the multimodal arm where we had a whole subset of cancers where there were rising biomarker levels, but the ultrasound was negative. So imaging, at least as it was available to us in between 2001 and 2011 did not seem to have the resolution to pick it up. I don't know if you've been following the literature, but with the Hopkins group, they've done Detect A, which is a multi-cancer early detection study, so not ovarian cancer specific. And there they've used PET-CT as the second line test. That is really a very preliminary study. The ovarian cancers in that set are all late stage, but it just made me feel that with PET-CT, you probably have higher sensitivity on imaging, but that is not cost effective really. You could do that in a study, but in real life, to either deliver it, logistics or the cost. But there are other efforts to improve imaging and the resolution of imaging. So, but it's a challenge. And at least from our group, our feeling is that if there is rising levels, so indicating increased risk and we can't find another cancer, we would encourage surgical laparoscopic removal of the tubes and the ovaries if the risk is considered high. And that's what our longitudinal algorithm did. And, I just want to emphasize that when we further worked on the longitudinal algorithms, multiple longitudinal algorithms will work in a similar way. It's not that you have to use ROCA, you can use the others, but we did allow the biomarker risk to override the imaging findings. But we waited until, we were absolutely sure before we pushed women to have surgery without imaging. Going down that list, I wanted to kind of pick up that question as to whether early cancers were aggressively treated. So we're doing a really detailed analysis, which we hope to publish either later this year, or maybe it'll come into publication only early next year, looking at the treatment in some detail of all these cancers to see how they were treated and whether that could have contributed. What I again want to clarify here is we must always keep the context of the time when the cancers were detected and when we did the trial. It was between 2001 and 2011. It was only after that maintenance therapy with bevacizumab and use of PARP inhibitors and all these newer drugs were licensed and began to be used, especially in the first line setting. So you couldn't absolutely extrapolate and say that if this be repeated and detected cancers, and in our case, we detected in 10%. So if you look at the difference in stage 1, stage 2 proportions in the screen arm versus the control arm, the difference was 10%. So, may not, whether that would have translated in the current setting, it's hard to know. The other thing, and I've heard this discussion outside ovarian cancer, because there's a lot of discussions going about early detection and what should we do when we early detect an aggressive cancer. And that is not only in the ovarian context, in pancreatic, in lung. And I think there's a feeling that we should treat these aggressively. Our usual way of treating stage 1 cancers is not to be as aggressive as we would be with stage 3 and 4. And there's a feeling that, at least I've started hearing discussions that from others, non-ovarian cancer people, that in this context, we should really be thinking much more carefully about how we treat screen detected cancers. I'll now hand over to Ian to take the next.
Thanks, Usha. There's quite a few questions about symptom awareness, which I think we should tackle. I'll just read them out. In regards to symptom awareness, while you state there's no improvement in outcome, can you talk about quality of life with earlier detection and healthcare burden? And then further down, if I understood you correctly, you said that focusing on symptoms awareness might not be a good direction in which to go. Is there something else as we as advocates should be doing? So the question of symptom awareness is, this study, of course, UKCTOCS was not an intervention based on symptom awareness, but it was based on early detection before women had symptoms. And given that we successfully detected ovarian cancer before women had symptoms, and that did not save lives, it then is very difficult to believe that symptom awareness when women actually have symptoms, so later in the disease, would save lives. And I think we need to be very careful about suggesting to anyone that acting on symptom awareness will save lives. Now, symptom awareness can, of course, have all sorts of other benefits. And one of the frustrating things for many women who develop ovarian cancer is that their symptoms, that others didn't pay attention to their symptoms, or sometimes that they feel they didn't. There can be many psychological benefits to acting quickly, and the requirements for treatment and other implications may be somewhat different. So I'm not suggesting that women should ignore symptoms, but I don't think we should hold out to women that symptom awareness will improve survival. Usha, do you want to comment on that?
Yeah, I just want to add to what Ian says, and emphasize that, as Ian concluded, that there's much more to being symptom awareness and getting a prompt diagnosis than just your life being saved. And that is right. We don't know, it may not save lives, but psychologically, it's really important, not only psychologically, in every way. If one of us had symptoms and we had ovarian cancer, we'd want to get diagnosed at the earliest. And really the effort in the NHS, and I guess in many places, you look at the WHO early detection aim, at this point, if you're talking about early detection, not screening, earlier detection in the symptomatic person, it is about trying to get this person diagnosed before they have a lot of morbidity, comorbidity, being very unwell, so that they cannot have appropriate treatment, or treatment has to be delayed, as well as, there is a real push to decrease the number of women who are diagnosed as an emergency admission through accident and emergency and casualty. So I think there is a role for symptom awareness, for making doctors aware about the symptoms, so that the referrals are all appropriate and, fast-tracked as much as possible. But, at least our studies suggest that it may not. And we must keep in mind that, we had only a 10% stage shift. So with that 10% stage shift, our studies, it suggests that whether it will save lives, that, we cannot, our evidence does not support that. But there's much more that symptom awareness, the goal of symptom awareness, at least as far as WHO and within the NHS where we work, is more about getting the woman diagnosed before she's very sick and before she comes through A&E, so that she can get the most appropriate therapy possible, even if she's in stage 3. So she could have upfront primary surgery as opposed to neoadjuvant chemotherapy and all of that.
Usha, do you want to pick another question?
Pick another question. Did you? So, there was a question about, did you notice any differences among genetic profiles? I'm HRD negative. So I just want to say that we haven't got any, two things. One is it's an average risk trial, and we excluded any women who were high risk based on family history, or because they had a mutation in their family, or they knew. So there were no high risk patients, at least that we knew. There would have been some who did not know they were high risk and we didn't. But it was generally an average risk population. And then the next thing is, we have not done any work on the tumors, and so we do not know anything much about their genetic profile to, kind of, from that point of view, see if there were any kind of differences based on genetic profile. We have, at this point, we're just looking very closely at differences based on the histotype, so low-grade serous, endometrioid, clear cell, high grades. And like I said, we've still got some more sort of analysis to do, but having looked at it, it does seem that the differences we got were in high-grade serous. So any stage shift we got was in high-grade serous. And in the other cancers, other subtypes, there wasn't a stage shift. That's because most of the type 1 cancers are diagnosed even in the control arm at an earlier stage. So what did you say? So is it practical to screen women and identify if they have early stage cancer or are pre-cancers? Can you comment on any research on the treatment to prevent ovarian cancer or to treat those earlier diagnosed earlier? So like I said, as far as prevention is concerned, it's really, you would have seen lots of work related to removal of the tubes. So it's not about, it's not about any drugs or chemo prevention. It's about removing the tubes, which we now increasingly know is where the high-grade serous cancer originates. So I think worldwide, among all the societies, obs and gynae societies and professionals, there is a move to remove the tubes at benign hysterectomy. Like previously, when we used to do a hysterectomy in a younger woman for benign reasons, we would leave behind the tube and the ovary. Now, increasingly, there is a trend to remove the tube with the uterus and leave behind the ovary. So that should impact, and all the modeling suggests, and some of the analysis from a hospital record data in the Swedish countries suggests that this will help prevent ovarian cancer decrease. And then there is, of course, an intervention in the high risk group. And you would have seen various trials which are underway. Protector from UK, in fact, one of our colleagues is running it as PI in the UK, but there is Tuber from, is the European trial. There is the trial from MD Anderson, and suddenly the name escapes me. But in all of these trials, they are inviting high-risk women to have their tubes removed. So it's it's not a randomization, it's a choice. But high-risk women are either having conventional removal of the tubes and ovaries or removal of the tubes alone with delayed removal of the ovaries. So these are the measures that are being done to try and prevent cancer. I haven't, at least I'm not aware of any advanced studies where chemo prevention is being used.
Sure, it may be worth us just adding a comment on the possible role of screening in women at high risk because of a very strong family history or a documented genetic predisposition such as BRCA1 or BRCA2. For that group of women, there have been separate studies, trials, big trials of ovarian cancer screening, one of which we've conducted in the UK and 2 studies in the USA. Those studies were not randomized trials. So amongst that high-risk group of women, we don't have evidence as to whether screening does or does not save lives. But we do know from those trials that ovarian cancer screening in high-risk women does pick up most of those women before they get symptoms, and it does shift the stage of disease, and it does make surgical treatment less complicated. So there is a debate now as to whether screening should be offered to women at high risk. Without screening, the options for those women are do nothing or have preventative surgery removing the tubes and ovaries. The standard advice to them is that the gold standard for them is when they've completed their families and they're ready to do it, to have surgery to remove the tubes and ovaries, because that is effective prevention. But if they are waiting for the right time to do that, or are absolutely determined not to have surgery after careful counseling, there is a debate then about whether screening has a role. And personally, I think it has a role in that situation. But the gold standard way of stopping them from getting cancer of the ovary is surgical prevention if they want to go ahead with it.
And just to continue on that thread, I just want to say that it could be that in the future, in some of these high-risk populations, because women or men would be at risk of multiple cancers, the new tests, and I guess you would all be aware because it's been in the news quite a bit, are gaining traction. How good they'll be, I do not know. They're very early in their sort of evaluation, but the multi-cancer early detection, or the pan-cancer tests as they are called. So the front runners you would have heard are from two companies. There's CancerSeek. The test is called by the company Thrive. It's come from Johns Hopkins. And then there is the GRAIL or the Galleri test from. And both of these, what they do, and I've been looking at what cancers they detect closely because of our own population. So both these tests, among the cancers that they're looking at, would be breast, ovary, pancreas, colon for the women with Lynch syndrome. So very relevant to our patient population. It's early days. I'm not saying that they are very good or they are, whether they will save lives, whether they, that is a bit far ahead. But they are being used in big studies. So there's big studies like where in breast screening, the test is being done alongside the breast MRI. So there's lots of studies looking at this. And in the next, I think by the middle of next year, there'll be quite a bit of data out there. So,
But Usha, just to be clear for everyone, it's really important that any purported screening test for ovarian cancer goes through a proper randomized trial. Because if you just looked at the ability of our screening test to pick up the cancer before symptoms and to pick it up early and to shift stage, you could then have concluded that that would be enough to save lives, and it was not. And there is a price for screening because there are false positives. Women have unnecessary surgery. Quite apart from the financial and economic cost of screening, there is also anxiety created by screening on a large scale. So we have to be really careful with this. And these tests, like the GRAIL test, are being heavily pushed and promoted. It is really important that before it is suggested that they used for ovarian cancer screening, they are properly studied, there are proper randomized trials, and the sad truth is that will take about 20 years to set up a trial big enough to answer the question. Perhaps not 20 years, but certainly more than 10 years. So we are somewhere away from having really solid evidence, even if the tests are really good, that ovarian cancer screening saves lives. Now we should pick a few of the other questions here. There was I was looking at one of these questions, Usha. I don't know whether you want to take this one. With the widespread use of PARP inhibitors and Avastin currently, can you comment on whether your results may have looked different had the patients on your trial had access to these game-changing drugs? That's a really tantalizing question.
Just to say, because I didn't take it because I had mentioned it earlier in, that our tests were done, we can't say, or it's difficult to know whether if we had, used these drugs and they were not available when we had understood the screening, whether it would have made a difference or not. And there's a lot of focus now on what should be the treatment of early detected cancer. So quite a bit of discussion on that. It may not be standard to give Avastin. Well, it depends which health system you're in, if you have a stage 1 cancer. But increasingly, there is a feeling that if it's screen detected, well, I shouldn't say increasingly, there is a discussion starting about how these cancers should be treated.
Yeah.
And I agree.
And it is a fascinating thought that what seems to have happened is that the women who would otherwise have presented clinically with advanced stage cancer were detected with at an early stage, but they still behaved in the same way as if they'd been detected at a more advanced stage, which is really frustrating. But you do just wonder if different therapies, when they were picked up earlier, could have changed the outcome. But that's just speculation, I'm afraid.
There is a question that Karen has asked, and someone has asked below, as to whether we could look at it. So I'm just looking at Karen's question. It says, can you speak to any analysis from UKCTOCS about differences in progression-free survival or survival between screen and unscreened populations who were diagnosed and treated similarly for OC, for ovarian cancer? So, it's quite hard to speak about survival because of, to look at survival from diagnosis, which is the usual way of looking at survival in treatment trials. We can't do that in screening trials because of the lead time bias and the length time bias. So there some biases creep in because if we might just detect earlier and the woman still dies or at the same time as she would have died, but apparently it looks like she survived longer just because we picked her up early. So there are some issues with regards to how we look at survival. So far, we have not published any data looking at survival, though we are working on it now. And one way to look at it is to look at it from randomization. And we will be sort of more formally kind of presenting that data in like I said, in this other publication, because it is subject to some biases, but we are keen to share that data.
Yeah.
Ian, do you want to say about
yeah,
that?
as Joan says, Karen's question is a good one. And I'm always looking to find some way that this trial did provide a benefit to women. And for most women, even if it doesn't save their life, if it gave them an extra 6, 12, 18 months, that, or it gave them time when they were progression-free and symptom-free that was longer, those things would be a real benefit of screening. And would be wonderful if we could show that. As Usha says, because of the nature of the trial, we have to be really careful that we're not just revealing biases in the way it's analyzed, rather than a real benefit to individual women. So it's quite a complex analysis, and I suspect that even when we do produce it, I suspect if we are suggesting that it does show a benefit, it will be quite controversial. But we will do our best to pull that out, and it would be wonderful if, despite the fact there was no mortality benefit, if there was a survival benefit, I, for one, would be very enthusiastic about women having access to screening, but we don't have evidence of that yet. Now, I think we're running out of time, but Usha, do you want to pick one?
Yeah,
One more question. I'm trying to see what we didn't answer.
So I'm just seeing Cynthia has written about, saving lives isn't the only goal. And I would like to just totally, support that with regards to the importance of awareness and early, getting to an early diagnosis in symptomatic women, because then, even if we could do lesser surgery, so still stage 3, we have to do debulking, but lesser surgery and less extensive surgery, each of these makes a difference to the quality of life. So do agree with earlier diagnosis. There are lots of benefits, but
there's a fascinating ethical and philosophical issue here, because we can pretty definitely say now that our screening approach, tragically, after 30 plus years of work and all of those great people involved and all the 200,000 women we're so grateful to for taking part, tragically, it doesn't save lives. So we cannot advocate population screening. It's very expensive, it has complications and all sorts of, raises all sorts of issues. Is it still then legitimate for individual women to say, I know all that, but there are other benefits of early detection for me, and I would like to access screening on an individual basis? I think that's a separate question. But what we're saying is that we cannot go to government or healthcare organizations and say you should be providing this on a population-wide basis, because probably the disadvantages and the costs and everything else, the complications, the false positives outweigh the benefits. Whether women should still be able to access it because they feel there are other benefits of early detection for them apart from a mortality benefit, that's a separate issue. And on that note, Usha, do you want to have the final comment before we hand back to Elizabeth and say thank you for letting us join you?
So as a final comment, can I just say, answer a question that Tonya has made, because, you know, this is information that's available. So there was a question about collecting information about previous hysterectomy prior to diagnosis and whether tubes were removed or not from the ovarian cancer survivors. Just to say that the more robust way of looking at this question is to look at everybody who's had hysterectomy with tubes removed and without tubes removed. And this kind of information is available. And that's why I said from the Swedish countries, they've already kind of reported it if you wanted to look it up, yeah, on 100,000, like huge numbers of women, because they have very extensive, well-documented hospital records and outcomes. So they know in their whole population who's had what and then who's. So just to say that, and then there are prospective studies going forwards, looking at everybody rather than doing what you're suggesting, which is a case control study where we look backwards, but there are studies looking forwards. And then I just want to echo what Ian has said. Thank you so much for having us here, for us to be able to kind of share with you some of the stuff that we have learned. UKCTOCS is a hugely, what I would say, the resource is full of insights. So we are trying to work with as many scientists and modelers across the globe, as well as biomarker scientists who are looking at new biomarkers, to try and make sure that everything that the women have provided and brings new insights into ovarian cancer screening. So there is a lot of data and samples available for study, and we're trying to be as open as we can. Till so far, we have not, whoever has asked, we have shared, and we hope we can do that going forwards. And that would be another additional way of trying to make sure that we get some really good insights.
So thank you everyone. Someone has asked, are our presentations available recorded? Because someone didn't manage to see them. Elizabeth, you might want to comment on that. I think they are. We certainly are happy for them to be shared. And then finally, thanks for the lovely comments at the end there. The compliments and the thank yous, really appreciated. Thanks to all of you for asking the questions and giving us the privilege of being able to join your meeting. I hope the rest of the meeting goes well. Take care, everyone.
Thank you very much. Thank you.